Good morning. I'd like to thank Dr. Joe Lombardi and the organizers of this esteemed summit for the opportunity to speak to you today. I'm Kim Dela Cruz, co-director of the Aortic Disease Program at UVA Health, and I'm tasked to present on the management of the aortic arch in acute type A aortic dissection. Here are my disclosures. Acute type A aortic dissection remains a challenging emergency, with operative mortality from about 10 to 25% across all databases. 10-year survival is about 50%, and 10-year intervention rate is about 30%. Life-threatening complications include tamponade, acute coronary syndrome, wide open aortic insufficiency, stroke, dead bowel, renal failure, and cold legs. Management of these complications has evolved to include hybrid, endovascular, and complex extended arch repairs, but ascending hemiarch replacement remain the most common, reliable standard. Here's a chart from the 2021 AATS expert consensus document on the surgical treatment of acute type A aortic dissection, showing key considerations in management, namely, after initial medical therapy, inter-hospital transfer, and surgical triage, axillary and direct aortic are reasonable cannulation strategies. Valve resuspension is effective in most patients. The entire ascending aorta with visible primary entry tear should be resected using open distal anastomosis. Certain conditions may require an extended arch replacement, and malperfusion syndrome with end organ dysfunction may be treated prior to proximal aortic repair. Mortality with malperfusion is as high as 60% compared to only 6% without malperfusion. The 2024 EACTS-STS guidelines echoes these principles, recommending a tear-oriented approach with exclusion or resection of the primary entry tear in the ascending aorta and aortic arch, and consideration for coverage of communications between lumens in the proximal descending aorta in specialized centers for prognostic reasons or aortic remodeling, as there remains to be about 50 to 70% false lumen patency rate after standard hemiarch repair. The main goal of the operation is to address the primary causes of death and disability, and to have a live patient at the end of the day with good long-term outlook and quality of life. And if possible, do an operation that could potentially decrease reinterventions in the patient's lifetime. This chart from the recent ACTS and STS guidelines advocates for extended arch repair with frozen elephant trunk versus standard ascending hemiarch replacement if the entry tear is in the outer curvature of the arch or within 10 centimeters distal to the left subclavian artery. Frozen elephant trunk is favored not only due to its ability to cover the entry tear, but also to prop open the true lumen in a more rigid fashion compared to the conventional elephant trunk to address distal malperfusion. Furthermore, the recent guidelines recommend arch replacement and creation of sufficient landing zone in the setting of multisegmental aneurysms of the thoracic aorta to facilitate further downstream repair with left subclavian artery revascularization to reduce the risk of stroke and paraplegia. Surgeons remain staunchly divided about the appropriate extent of distal repair for dissection, extending into the aortic arch and beyond. Optimal management of the aortic arch in patients with acute type A aortic dissection should balance the risk of extended arch replacement with the benefit of additional resection of dissected aorta. Options include, number one, resecting and replacing the lesser curvature of the aortic arch with the standard hemiarch replacement. Number two, replacing the entire arch. Number three, extending coverage into the proximal descending thoracic aorta with a frozen elephant trunk or antegrade T-bar. And number four, use of the AMDS device with true lumen deployment of a bare stent from zone 0 with an ascending replacement. Here's an example of a homemade frozen elephant trunk with antegrade T-bar deployment in zone 2. Then sewing a Dacron graft with a side branch for distal perfusion at zone 2, incorporating the proximal end of the stent graft. And a Y graft to the innominate and left common carotid arteries, which is attached to the proximal portion of the ascending aortic graft. I'd recently just started at UVA last few weeks, and we're currently in the process of looking at our data. And in my previous institution at the Brigham, where I had spent the last few years, our yearly volume of acute type A dissections has increased since the early 2000s, peaking in 2020 at 42. As volume increased, we also perform more total arch repairs, as informed by the clinical characteristics of the patients, such as intimal tears in the arch, though the repair of choice is generally a hemiarch. We have performed hemiarches in approximately 80% of our patients. Roughly 70 to 75% of our patients are transferred from outside institutions, lending to a high degree of complexity, including nearly 30% of patients presenting with malperfusion syndrome, primarily of the coronaries or lower extremities. We average about 60 of these per year. The decision to perform either a hemiarch or more aggressive arch reconstruction remains a point of controversy because of the tension between a generally higher rate of perioperative complications for more extensive repairs versus the putative benefit of decreased future repeat intervention and potentially improved survival. Our general experience has found that total arch repairs are associated with higher rates of stroke, though this is in part because of the high rate of cerebral malperfusion syndrome in these patients at the time of presentation. Otherwise, acute outcomes are generally similar between hemiarch and total arch repairs. The overall similarity in outcomes is recapitulated in the survival data, which demonstrates no significant difference, P of 0.6, in long-term survival between patients undergoing hemiarch or total arch up to about 10 years post-op. Therefore, our institutional experience supports that judicious patient selection for more aggressive arch reconstruction during the index surgery can lead to similar short and long-term outcomes compared to those with less extensive repairs. In conclusion, do an aortic arch replacement with frozen elephant trunk in acute type A dissection when the aortic arch is large, when there is a non-repairable tear in the greater curvature of the arch, when there is rupture in the arch or proximal descending aorta, and when there's malperfusion to the arch vessels and or downstream. Consider arch replacement with frozen elephant trunk in a young, otherwise healthy patient with heritable thoracic aortic disease or connective tissue disorder, especially if the arch diameter is greater than 4 centimeters. And individualized treatment based on clinical and anatomical characteristics, and take into consideration logistical challenges in the final treatment plan. Thank you so much for your attention.